Good afternoon, ladies and gentlemen. My gratitude to Dr. Sanjeev and Dr. Hemant for giving me this opportunity. I think next 2.5 hours you are going to discuss sepsis and related issue. I am just going to give you the present definition and little bit of understanding about the sepsis. The latest definition of sepsis appeared only last year, which is called Sepsis 3. You know, prior to this, the first Sepsis 1 sitting was in 1991-92, 25 years back, and that point of time, sepsis was thought to be SIRS related, and sepsis was defined as a proven or presumed infection fulfilling 2 of the 4 SIRS criteria. Severe sepsis if there was an organ dysfunction, and septic shock if there was persistence of hypotension despite fluid resuscitation. There was no quantification given in this definition. 10 years later, in 2001, there was a second consensus definition. They only expanded the criteria, diagnostic criteria. However, there was no change in the definition. We all know there are a lot of limitations to this SIRS-based definition because these are non-specific criteria. We know that 90% of the ICU admissions fulfill SIRS criteria. They may not be having sepsis. And the large data from New Zealand and Australia shows that 1 in 8 patients of proven sepsis does not fulfill the criteria of SIRS. And the misconception that possibly there is a sequence of events from SIRS to sepsis to severe sepsis and septic shock. Therefore, there was a jury of 19 experts who dwelled on the issue for over a year, and finally they came up with the definition of sepsis, which is now defined as 2 things. There is organ dysfunction, which is caused by dysregulated host response. We all get infection, and normally there is a regulated host response, infection goes. But if there is a dysregulated immune response and there is an organ dysfunction, it becomes sepsis. For quick identification and screening, they devised quick SOFA scores. There was a comparison of many scores which should be ideally used, and it was decided that we should use quick SOFA score. As per this, if a person fulfills 2 of the 3 criteria, that is altered mentation, systolic BP of less than 100, or respiratory rate of over 22, 2 of the 3 criteria, he will be defined to have sepsis. Now, this is very useful for emergency department. That means the emergency doctor who is sitting there, where should he send the patient? If he knows that quick SOFA-wise patient fills into sepsis, he probably will send this patient to ICU, the other patient will go to the ward. Now, for defining quick SOFA, they compared many criteria on a large number of patients, and the validation was done that for ICU settings, one should use SOFA score, and for outside ICU setting, one should use Q SOFA or quick SOFA scores, which are statistically important. Now, this is the SOFA score. You know that it takes into consideration 6 systems: respiration, coagulation, liver, cardiovascular, CNS, and renal, and each one has got 4 scores. That means a total score of 24. Now, what is septic shock? Septic shock was defined as that subset of patients of sepsis who have 2 of these criteria. That means if there is a need for vasopressors to maintain a systolic BP of mean arterial pressure of over 65, and 2, if lactate levels are more than 2, that means if these 2 criteria are fulfilled, he can be classified as septic shock. Present day, there is no place for terminologies as severe sepsis, sepsis syndrome, or septicemia. These are today obsolete terms. Well, if going to the statistics, you know around 30 million people world over develop sepsis every year, and there is a 30% mortality. Even the survivors are left, many of them are left with disability. If you go to the sepsis fact sheet of 2016, you find that the 62% of patients hospitalized for sepsis will require rehospitalization in the next 30 days. Every hour of delay in starting treatment increases the risk of death by 8%. This only necessitates how early you have to act. And 80% of the sepsis deaths are preventable because they are all community acquired. Now, unfortunately, the incidence of sepsis, because of the longevity, because of the complex diseases, because of the procedures, is increasing every year from 8 to 13%. Septicemia in US also is the most expensive disease to treat. It is much more expensive to treat sepsis than MI or any other stroke or any other disease. Now, if you look at which organ system is the foci from where the infection comes, commonest remains respiratory, followed by urological causes. And if we go to the bugs which are responsible, it is an old slide because this is still true, that is why I am giving it. Gram-negative, followed by gram-positive, followed by polymicrobial, and followed by fungal. This is the sequence and commonness of source of infection. Even the Indian data, one of the published data, which again shows that ICU mortality of all admission was 12%. However, for severe sepsis, the old definition was 60%. This is higher than the world reported figures. The culture positivity was found in 61%. This is too high. The world over, culture positivity is around 40% or so, and the lung was the dominant source as world over. The gram-negative organism were responsible, which is equivalent or equal to the international data. Now, if you see which age is susceptible, you know the neonates, less than 1 neonatal, 28 days and below, and the old age, they are the susceptible population. And if you look at the mortality, as the age increases, as the comorbid conditions increase, the mortality keeps increasing. It is heartening to know that the mortality rate in sepsis is gradually coming down because of early diagnosis, because of antibiotics, early recognition, and the therapies available, but it still remains much higher than the non-sepsis patient in ICU. Now, these are the surviving sepsis campaigns, and they have devised bundles. That means if within 3 hours of person reporting to the emergency department, you should have measured lactate levels, you should have obtained blood cultures, you should have administered antibiotics, and you should have given 30 ml of crystalloids if there is a hypotension to treat that. That because, as I mentioned, every hour of delay is proving to be very expensive. And likewise, there are bundles, treatment bundles designed for 6 hours. Now, if you go to the pathophysiology, just a minute on that. Today we know that the immune cells, whether it's a macrophage or lymphocyte, they have got receptors on that, which is called the pattern recognition receptors. There are 4 of them, toll-like, C-type, retinoic acid, and nucleotide. And they recognize the pattern recognition receptor. They are not recognizing the organism. They are recognizing the pattern on them. And once these are bound and they go inside, they stimulate the receptor, which starts the inflammatory process inside. If you look at, now 2 events are simultaneously going when the sepsis is there. First is the pro-inflammatory pathway. That is very important. That is the early phase of pro-inflammation, and here there is a cytokine storm because the leukocytes get activated, their cytokine, the proteases, and the reactive oxygen species. There is a complement activation, and there is a coagulation pathway which goes on. There is a cell death, and from cell death there is a death-related danger signals which come, which again activate the lymphocyte or neutrophils and macrophages. And at the same time, there is an anti-inflammatory pathway. That is what you call immune paralysis. Because following sepsis, the immune system gets is just lying quiet and this is what you call immune paralysis. That is why patients with sepsis are much more prone to develop infections. And what happens, ischemia gradually is occurring because there is a thrombosis and there is a capillary leak, which both add to the tissue decreased perfusion and oxygenation. Now, this is important to understand that initially there is pro-inflammatory cycle, and after that there is an anti-inflammatory or immune paralysis cycle, and many times they go simultaneously. This may not be the sequence what I am showing. If you look at the organ failure which are common, it is the renal and pulmonary organs which fail. Talking a minute about the kidney, the AKI incidence is higher as you go from sepsis to bad sepsis, and now you go to septic shock. And approximately 10 to 12% of patients with sepsis and over 60% with septic shock develop AKI. Look at these, all the criteria adopted. If, I'll take 1 minute. Right, even if it is not there, we can go ahead that the septic shock is there, the incidence of AKI is pretty high, and even if this is the data from 57 ICUs, only initial 24 hours, if you see, the incidence of risk, injury, or all kind of rifle in septic patient is much higher. This is the same ICU length of stay, the hospital stay, and discharge to secondary places is much higher in septic patient versus non-septic patient. This is again the similar study, and logically the mortality is much higher. Now, 2 points only. In sepsis, renal blood flow is not reduced. Mind you, we always talk there is a hypoperfusion. There is no hypoperfusion today, rather there is a hyperperfusion. What is occurring? There is an efferent vasodilatation. So there is a high flow, low filtration. That is why norepinephrine and vasopressin are effective, because they cause vasoconstriction. And secondly, there is no acute tubular necrosis. There is more of tubular apoptosis and leukocyte infiltration. So today, we need to identify novel biomarkers which are coming. This is an article from Dr. Anupam Agarwal in JASN, which is showing that few of these markers are going to come, and that will ease in identifying that which is the patient who is having. And the last slide, therapeutic modalities today will aim at two things. You have to identify, are you at a pro-inflammatory path, initial path, when you will have to use different, these are some of the parameters are that pattern recognition, the system, what is there, it will block them. And secondly, if a person is on immune paralysis, you will go for interleukin 7, interleukin 15, or GM-CSF, so that you can increase the immune system in a person who is already paralyzed. I'll stop here, because now I think the next speakers are going to talk that whatever cytokine storm is there, whether they are modalities which can remove the cytokine storm, possibly the adsorption technique, the CRRT techniques, which the next speakers are going to talk. I'll stop here, and this is what is the sepsis.
Thank you, Dr. Varma. He has given a most current, comprehensive and global account of sepsis. As there is time is less, I think we will not allow any questions and comment.